Yeah, we did it in the AGM, didn't we? I am just going to take the opportunity to welcome two individuals, one of whom is here. Firstly, Andrea, who's been appointed as our Chief Financial Officer, albeit on an interim basis, but I'm sure that will be a long and happy relationship with us. And Janelle Holmes, who's been appointed as the partner member for the acute sector. Janelle, unfortunately, couldn't stay for the meeting this afternoon. And I'm going to use... So I need to go back to the agenda. Let me just ask for any declarations of interest. Good. So I can go now into my chair's remarks, which I just started then. So I'm going to use the opportunity, and she is absent, just to thank Anne Marr again. She brought deep experience, a wiliness, and some challenge, I guess, into the ICB, and not all of us agreed with it all the time, but she made a real difference to us. And Janelle's got some big shoes to fill. Hopefully she'll fill it in slightly different way on occasions. But well, I've said that to Anne personally, so I'm sure on behalf of the board we recognise what Anne has contributed, and we wish her well. That's the end of my chair's comments. I think we're going to... Who's going to introduce the experience and achievement story? Is anyone going to do that? So I think I've got a prompt here around Get Britain Working and the health and work strategy, and it says Ian and Del may well want to speak to it.
Very quickly, you've got a fantastic example of the video coming through about the importance of supporting our residents into meaningful employment, and later on in the agenda you'll hear some of the fantastic work our colleagues in economic growth, local authorities and skills do, and our role that contributes to the fourth objective of the ICB around the economic sector locally as well. So what you'll see now is a short video, I hope, of some great work in Cheshire West and Chester.
The Supported Employment Service helps people with learning disabilities or autism to find and keep paid work.
Service, the Supported Employment Service, he introduced me to Josh, which was a potential candidate.
Colin's helped me out doing my CV, and because I'd never done a CV, I don't know how to do a CV until Colin helped me out. And I thought, this is actually my CV. This is actually going to get me the job I'm looking for.
And from then, we went over to a working interview, which was perfect because Josh was a bit shy at first, so actually being able to work was his way of showcasing his abilities in the best way possible. When Josh first started to work here, he was supported by a work coach, which helped him fit in with the team and feel more comfortable on his first weeks.
Just to help me to build up my confidence, because I knew I've got someone to talk to.
It has been great since Josh just started to work with our team, because it helped not only me but the whole staff understand autism a bit more, and now they know that a person with autism can do everything as just we can do, and if we just help them fit in and feel comfortable, they will be able to do an amazing job.
And my employer's brilliant. I get on with every single staff I meet. If I need help, they're here to help me.
It is really important for us as a company to have a diverse workforce, because that makes us feel like we are giving an opportunity to everyone, and it just helps our company thrive as well.
I feel powerful with my job. I'm proud of my job, and I absolutely love this job. I'm more independent, I get out and about, and also it helps me to influence more people to look for a job.
One of the best things about the employment support service is knowing that whenever you need a helping hand, there's always someone there to reach out, and the support will be continuous throughout the whole employment.
Please get in touch if you would like to access this free service from the Supported Employment team.
Good stuff. Ian Dell?
Yeah, just a comment. I mean, it speaks for itself, but it's a really nice, well-tailored service which matches the skills of prospective employees who have a learning disability or autism into and linking into employers. We offer induction, coaching, support, tailoring skills. You know, it's a really holistic service. We've supported, I think, at last look, about 100 people, 60 of which are now in paid employment, and it links into getting Britain working. So we've got about 100,000 inactive people across Cheshire and Warrington. Cheshire West are the lead authority for this type of work, but this is specific to LD and autism. But it's great to see some of the outcomes now starting to filter through. So I think there'll be more to hear in the future.
Fabulous. Fabulous work. Okay, so let's go on to the report of the Chief Exec.
Thank you very much. So hello, my name's Cathy Elliott. I am the Chief Exec of NHS Cheshire and Merseyside. It is an extensive report. This is my second report to the board, having joined in June. And particularly what I wanted to do is represent the executive team of the ICB and sharing a variety of pieces of work that are going on within the ICB and with our local partners. So you have a number of examples there around services, for example, around cancer diagnosis, research and development, and also around work on Altogether Fairer, which we referenced in our AGM recently in the Altogether Smiling campaign. There are a key document in the report today, which is in the appendix. This is something we wanted to recognise as an organisation and as a local partner, as well as a commissioner, around the information that is out in the public domain in terms of the NHS trusts, acute community and mental health trusts, in terms of how they are ranked or tiered. And we hope that's really helpful for board members, for health and care leaders, but also for members of the public. And we have made sure that we've put an explanation in the report about how those are different, because 1 to 5 in one segmentation, 1 may be good, but in tiering 1 to 3, for example, is different and 1 is not so good. We recognise that the public rankings have taken place across the NHS for our trust colleagues, and we wanted to also give a balanced view there in the Care Quality Commission, the CQC ratings as well, which is a much more holistic overview. So thanks to my colleague Anthony Middleton and other colleagues who've put this together, and we'll commit to regularly do this just to give a sort of a snapshot of where NHS trusts are. And the other areas I just wanted to highlight, not only a list of executive team decisions, which we'll continue to report on, particularly as we finesse and our governance arrangements as an ICB, particularly through a reset of our executive group, becoming an executive committee. We will continue with that. So if I work backwards in the report, there are also reference to Model ICB and Model Region. This is all part of the NHS reforms taking place, announced at national level since March this year. We've had documentation to guide our reform and unfortunately cuts within the ICB since May this year particularly, and we've had additional information coming through on the 8th of September this year, which we're continuing to respond to, working within the ICB across our system and with our colleagues at NHS England Region and our neighbouring systems, Lancashire and South Cumbria and Greater Manchester. And I want to particularly thank, but also note for the minutes that we have had in place since May-June time, a transition group of our chair and non-execs having oversight of this work, and as we need to, we've then taken it into more formal forums such as our remuneration committee. And then going back to the beginning of my report, really want to celebrate the fact that we have 2 places who have been awarded neighbourhood health care status, pioneers nationally. So we have 2 out of 43. I think we're the only system with 2. And another system can come and contend that if they wish to. It's a real great celebration of St Helens and Sefton's work. As colleagues know, neighbourhood healthcare laying down the foundations of very much in NHS guidance for this financial year, but in the 10-year health plan, and how fantastic it is for us that we have 2 out of our 9 places in Cheshire and Merseyside system being recognised nationally. This is an opportunity to accelerate neighbourhood health services, and work particularly effective across the breadth and depth of health and care, social care, NHS, that's secondary and primary care, voluntary sector, and those broader aims as well around health and work and health and housing, and we're going to hear more about health and work later. But what we aim to do, particularly aligned to our neighbourhood health framework that we developed and brought to the board in July, make sure that all places and all of our neighbourhoods, and our intention to have around 50 neighbourhoods across our 9 places in Cheshire and Merseyside, will benefit from this national opportunity. So, thank you.
Going to take any questions or comments? No? Thanks, Cathy. Interesting report. Andrea.
Thank you, Chair. So thank you, everybody. My name is Andrea McGee. I'm the Interim Finance Director. And I'm just going to try to lift out of the report and the supplementary slides the highlights in terms of month 3 and month 4 position. And, you know, what are the key messages that are emerging and what steps do we need to take this year? So for those that are looking at the pack, on page 25 of the pack, or page 4 of the report, is chart 1, which is a very helpful graph that shows, first of all, there's a blue dotted line on that graph, which is our £178 million system deficit plan. So we're trying to achieve that 178 million deficit, and we will be able to earn £178 million of deficit support funding to go along with that will take us to a break even. So it's really important that we're able to earn that deficit support funding. What I would say at the moment is that we are showing, with regards to our run rate, that we're not getting close to that 178 million. So our current run rate, how much we're spending month on month, is taking us to a 385 million deficit, that red line, which is a significant gap. And that isn't surprising at this point in time, given that the plans are clearly backloaded. So if we look at month 3, we had a planned deficit of 96 million, a planned deficit of 97 million and achieved 96 million. Now that is more than half of the whole year plan after 3 months. So we were already halfway towards that 178 million within 3 months of the financial year. And when we move to month 4, we actually go off plan and have an adverse variance. So at month 4, we have a deterioration with a 139.5 million deficit. So what's really important is that we have underpinning efficiency plans to bring us back to the 178 million plan that we set out at the start of the year. So we need to start to make inroads to that run rate in the second half of the financial year. From a CIP point of view, we have been delivering efficiencies, which is very positive. However, around a third of that CIP that we're delivering is non-recurrent. So that would be a concern going into next year, and we're looking at lots of one-off ways to make savings. So it's really important to get credibility back into our system around those efficiency plans and how they will get pace and gather pace in the second half of the year to start to reverse that downward red line that you can see on that graph. The size of the efficiency challenge is very, very, very large scale. So the ICB has to deliver £139 million worth of efficiencies, and the providers 433 million. And on top of that, we agreed earlier in the year a stretch between the providers and the collaborative of 235 million. So that is a significant challenge for the ICB and across the whole of the ICS itself. So we need to start to look at delivering plans that are recurrent in nature and that gather pace in the second half of the year. Some concerns arising from an ICB point of view that are outlined in the paper are relating to overspends in a number of key areas. Those areas are spend on acute care, particularly in the independent sector, overspends on mental health services, predominantly ADHD, which could take us to a significant overspend of potentially around £18 million, and overspends around primary care prescribing. So we really need to get a grip around the overspends that are occurring in year, otherwise we'll need to then deliver more mitigations on top of those efficiency plans that we're already seeing under development. The impact of all of this is that organisations are starting to run out of cash. So that's a problem. We will see our better payment practice code, so the rate at which we pay our creditors, the people that we owe money to, deteriorate to levels that we don't want to deteriorate to. So the cash situation is a challenge, and we're finding more trusts moving into a distressed cash position. So at month 4, we had 5 trusts in receipt of distressed cash funding to the value of £49 million. So so at this point in time, we're in turnaround as a whole system. We've got we're deemed a high risk, low confidence ICB, and we need to turn that around, and we need to turn it around at pace. We have to make a case back to the system to say that we are very, very clear about the things that we are going to do to move us back towards that £178 million plan for the start of the year. And if we are able to do that, we will get the full £178 million into the Cheshire and Merseyside system. So it's really important we start to see those very credible plans, much more developed than they are now. Some green shoots in terms of some of the delivery. But that credibility, that change in the run rate is really important. There's lots of information in the pack around pay. And one of the big challenges is that despite all the work that's being done around pay, we're not seeing any significant shift around our pay run rate. So we've got a very, very challenging position. We've still got half the year left, so we've still got road left in the year, and that's important. Over the coming weeks, we're going to be looking at how do we, as an ICB, really satisfy ourselves that we are clear about all of the things that we're able to do and doing to support the ICB position, and working with our providers in the system, looking at getting assurances around their plans in terms of their delivery as well. So there's a lot of work to do at pace, but we need to move quickly because time will be against us. I'm happy to take any questions.
Thank you, Andrea. Any questions? Finance report? No? Okay. Mike, should we go on to the committee report?
Yes, thank you. The report gives a summary of the meetings that were held in July and August, but we've actually had a third FERC committee which was held 2 days ago, so I could perhaps just provide a few verbal comments from that meeting. The focus of the work has been around the topic that Andrew's just covered in the main, in terms of our financial challenge, and it remains severe. In terms of the work of the committee, I think it's clear we're going to have to step up some of the work we do in certain areas. I think I get an increasing understanding from NHS England that they want us to do a much more detailed tracking of the cost improvements, in particular those of the ICB, and then test the remediation plans we may have if that tracking indicates that we're off course, and that does seem to be the case, and then to derive from that an assessment of the financial risk that we are carrying. So I think the agenda of the committee in the future does have to change slightly. Still going to be looking at the same topic areas, they don't change, but I think forensic nature and deriving that assessment is what the expectation of the committee is going to be in the future. I also just want to make very brief reference to the paper that Claire presented earlier around the 26-27 planning, because there's a very important component of that Andrew's already mentioned in relation to the reset of contract values for next year. And we've already had signals from Secretary of State that deficit support funding is going to be withdrawn. It may come back in some form of allocation. We know not what yet. But those two factors combined, given the underlying deficit position we've got, do mean that if we think this year's challenging, 26-27 is going to be challenging in ways that we don't yet know. And in particular for individual organisations with that contract reset. So there's a really significant amount of work that needs to take place to get us prepared for 26-27. The technical work before we then turn to the challenge of what that means in terms of the recovery work and how that needs to be put in place and how it lands on individual organisations. Can't overstate the importance of that piece of work. Happy to take questions, Chair.
Thanks, Mike. Any questions? Nope. Okay. Some really important points there. Should we go, Anthony, should we go on to the integrated report?
Yeah, thank you, Chairman. And if you'll permit me, Chairman, it's clearly a meeting of reflection. I think if I reflect on a really thought-provoking discussion we had last week about sometimes how our system is perceived in terms of delivery, I started to look at that in the context of the way that we present some of this information here. It's a report that we have continued to develop, and I think what we see here is not only does it include all the core items that we are accountable for, we have quite rightly included all the areas that we already know are off track, and we've started to feed that into the report so that we can track progress. It can be easy at first glance to look at a sea of red and come very much to a conclusion about our overall delivery. But what I'd probably advise some of the board members to look over to the right-hand side of this report, where you see how our performance compares with other systems. And if we take those 35 national priorities, which are within the overall report of this, what you actually see is that the vast majority of our indicators are in the middle ranking of comparable systems. And indeed, in some cases, like cancer and diagnostics, we are absolutely up there with the top quartile performance of the country. We know where our problem areas are. It's UEC and long waits for elective, but I think it's a really helpful way of trying to put it in a much more balanced view. If I touch on UEC, I'm not going to say too much because the board will receive a deep dive presentation on what we're doing around the UEC programme. But what I would draw the attention to is the improved performance around ambulance handover response times and the ambulance handover times that's in our system. The latter being the first time since the ICB was established where we've fallen below 30 minutes for average handover at hospital. That was based upon a real initiative to absolutely put in a 45-minute backstop that we commenced in August with earnest, but we were rolling out from July. And whilst that has had some initial impact on performance against 4 hours, the more recent information would suggest we're bouncing back from that. And similarly, I think if we look at non-criteria to reserve, which has been a perennial challenge across Cheshire and Mersey, we look at the overall position, the percentage of beds occupied, and I've included that back into the report over here. Whilst it appears static, I would also draw your attention to the actual time that patients are delayed is heading in the right direction at now 8.4 days from a peak of near 10.5. Similarly, if I look at elective, after a period in Q1 where the number of long waiting patients increased as the system tried to provide some level of balance between core capacity, efficiency and financial resources, it's pleasing to see that for the second successive month, those numbers of long waiters, as in those over 65 weeks, have fallen. We need to recognise that only last week the NHS leadership team presented to all chief execs down in London that they have a very, very clear directive that focus must be maintained, and a very clear expectation that 65-week waits will be eliminated by no later than December. And that an equal focus is also impressed upon that overall waiting list numbers do not increase, although that will be judged at regional level, not necessarily ICB. We do have detailed plans on that and oversight and arrangements, and that absolutely is pointing to us being able to achieve that timescale, in some cases much sooner than December. But there are some real challenges around individual providers and individual specialties, but as I say, overall, we do have the confidence that those plans will show that achievement. We did touch on this at the last Quality and Performance Committee, and we agreed that we'll bring back the detail of those plans to the next meeting, and indeed we're sharing that with NHS England next Wednesday at our system delivery meeting. So I'll pause there, Chairman, and open it up to questions.
Thank you, Anthony. Any questions or comments? Ruth?
Just wanted to come back to services at the Women's Hospital and the performance on cancer. It seems quite a strong outlier compared to all the other organisations. So any comment you can make about both the delay in access to the initial diagnosis and the delay in telling people the outcome of that initial assessment? And of course, you would expect me, having raised it at most meetings, what we think about our healthcare acquired infection rates and the fact that we've almost got the whole year trajectory to occurring in the first 6 months. I know we put plans in place, but we should have an update. Thank you.
I'm sure Chris will come back on the infection challenge. Yes, the outlying Liverpool Women's is an outlying performance in terms of that tumour site, and I think it would be easy to explain to simply say, well, that's the tertiary centre, and therefore all the complex cancer referrals will go over to Liverpool Women's. What we are doing with some of the stuff that James didn't mention earlier this morning, actually, but also in collaboration with the Cancer Alliance, is that we are looking to ensure that the non-tertiary work that the Liverpool Women's currently performs is directed to other parts of the Liverpool Group system, so that we can get on top of that time and make it much more equitable across the system.
Chris?
It's working now. Yeah, just looking at the Clostridium difficile and the E. coli. So we launched the toolkit, the CDI toolkit within the system, and we had seen a decline in CDI, and we're continuing to work with the two trusts that are the outliers. So there's probably some natural variation in there, so there's still further work to do, and we're working with those two organisations that have been identified as outliers. We are still meeting as a system around HCAI, and I too hope to see that those figures will continue. There is to decline. There is still the issues around community acquired as well, so we do need to focus on that.
Ron?
Thanks. Myself and colleagues remain concerned, particularly when we're looking at our RTT performance over 65 weeks, that we've got one of our trusts in particular continuing to struggle with this despite support of mutual aid amongst other things being brought to bear. And at the point I'm now working with Chris to construct a rapid quality review to really step in, sit next to them, fully understand the problem and see where some fresh thinking can bring something to bear. It's been really stubborn managing down 65 weeks in certain parts of the system, to the point that I can no longer just let that keep being observed, but instead to intervene.
Thank you, Rowan. Anthony, a couple of questions from me. One is on the community services waiting list. The question really is, it just seems a low number of people. So I'm assuming that that's not a comprehensive.
Absolutely not. For a number of years, both in community services and some mental health services, we've just not been capturing those waiting lists. They've been hidden. and it's part of the programme that's underway to make sure that we capture that. Interestingly, as in what Cathy mentioned before, the performance against those and waiting lists is now being incorporated into the provider oversight ratings. So even though that's been a bit of a challenge from the first cut of those ratings, that some organisations are appearing to have a higher rating simply because they're not reporting the waiting lists, and that's what we're looking to address before the next cut of those provider oversight ratings, which, by the way, are now included in this report as well.
Thanks, Anthony. And clearly, the board will need to be cited on waiting times in communities in the holistic, from a whole perspective, especially as we try to achieve our shifts. Hello, are you waving at me on this point? I had just one other point. No. Okay. And the other one that just pick out we haven't talked about for a while is neurosurgery waiting lists growing again.
Yes, I haven't got too much detail to spread back on that, but obviously most of our neurosurgery list is located within one site of Walton. I'll come back with more detail on that, Chair.
Okay, thank you. Hilary?
Yeah, CHC, so a standard referrals completed within 28 days, deteriorating, and I just wonder, that's just less than 10%. What does that mean in terms of numbers of people waiting for assessment, and where are they waiting? And a delay in assessment just doesn't have impact on deteriorating patients. This could be the difference. If we leave these people too long, it could be the difference between people going home or losing their home. It's quite significant. So I just wonder, how many patients does that refer to, and do we know where they are?
Thanks.
So, Hilary, I'd have to get back to you. It is not many. I will get back to you on the numbers, but we absolutely know where those people will be waiting. I think the metric that we do perform well on is we do not carry out those assessments in hospital. So as far as possible, we are discharging people to assess, whether that's to a care home or within their own home, and assessing there. But geographically by place, we absolutely do know the places that are struggling to hit those targets. And it's mainly those with the workforce issues that we understand. So more in Liverpool and Sefton at the minute waiting because of some of the workforce pressures there. In some of our other patches, and we're really, really hitting that target well. But I can come back to you with the numbers if that helps.
Thanks, Alison. Just while I'm on my feet, can I ask another question as well? And that's around the conversion rates for CHC. And over lunchtime, I just looked at the national conversion rate, which range from 25 to 32%. So that accommodates different geographical areas with different demography. But obviously, we're much higher than that. And do we really, I'm inferring, is this a clinical practice issue that we've got? Do we really understand what's driving our high conversion rates?
I think, Chris, you might want to come in here, but we know there is variation in our teams across. We have 5 teams serving our 9 places. We've got some very experienced and good leaders leading those teams. We've got others with less experienced people. So there is absolutely variation. Some of that is to do with the demographics, but some of that is that variation in clinical practice that we have to tackle.
Yeah, and I suppose that leads me to think, is there something that we really need to do intensively now in terms of that clinical leadership, particularly in time for winter? Is there an intervention we could put in to lift the clinical practice standards up?
Yeah,
Thank you.
There is variation, and what we've done is looked at the heads of service we've got, and we're using a peer approach, so they are supporting in different areas. So we've got a fresh set of eyes going into a different area to look at their assessment processes and support. So yeah, there is something we can do. We need to look at a standardised approach, get there. The issues are around. We have got significant vacancies and also a number of issues of sickness and absence within the team. But Alison and I are working with the heads of service to look at how we can do that across the system and get a standardised approach.
Thanks.
Thank you. And Andrea?
So just on that, this is a really high area of expenditure for the ICB. So, we're red across the board there. So we need to do something very quickly on this, because we're talking about quality of care, but we're also talking about extremely high cost of care as well. So I think we need to inject some pace into that, and happy to support looking at how we do that and organise ourselves to wrap ourselves around that if we've got issues around sickness and vacancies. Thank you.
Thanks, Andrew, that's helpful. Okay, unless there's any further comments, I'll move us on. And Anthony, your point at the beginning, making sure we've got a balanced view of the good performance versus the challenging performance, is really important, if nothing else, just to our mindset. So thank you for that. I think, Tony?
Yeah, thanks, Raj. Apologies, we haven't a written report at this point. It was just the timing of meetings, but this was just to provide a link, and we'll follow up at the next board meeting. And it was a sequence of reports that raised some concerns in the committee. It started off with the Children Looked After annual reports, such as Children in Care, and our continued difficulty in meeting the standard for initial health assessments and repeat health assessments. This is not the same as last year, but it's been a continued concern, and it seems to be showing some signs of becoming almost intractable. So the discussion was about the reasons why, and the risks in the report pointed to staffing shortages in specialist roles, particularly designated professionals, the rising complexity of health needs of children in care, especially around mental health, which has resulted in our non-compliance of statutory timelines for health assessments. So that was one report. We then continued with the second report, also about safeguarding issues on domestic abuse and sexual safety. The ongoing work on updates on safeguarding responses highlighted the need for a robust multi-agency coordination. That's clearly evidence, but again, the risks emerged as designated professionals operating under pressure with teams with significant vacancies, and a lack of clarity from NHS England about the model ICB blueprint and the national operating model for safeguarding. This combination of things is becoming to be as great a concern as the actual data that says we're not meeting safeguarding targets. So there's an emerging larger scale risk here that Chris, I think, wants to comment on.
Yeah, thanks, Tony. So yes, the safeguarding function within the ICB, we have been working on a business continuity model over the last year, as we've also been doing for our special educational needs and disabilities team. And we've been looking at how we can deliver this function across the system. However, we've now got to the point where obviously with the concerns around how the future for these functions will sit, and we were waiting for the model ICB blueprint. I did approach Cathy, and we've been working quite closely with Mike to look at how we can ensure that we have the appropriate coverage and that we have the right staff within place. So we have a paper going back to Cathy and Mike. We've been working together with our safeguarding leads, also our designated professionals, as to what is it that we can do to support in the interim in either posts from within the system or maybe a temporary measure, but we do have some vacancies in this function. So we've been working with Paul Martin within HR, and we'll feed that back through to Cathy, but we'll also take it back through to Tony as chair within the QPC, and there'll be discussion at the next meeting. We've got a couple of workshops coming up with the designated professionals, because we were clear that we wanted the staff who were delivering this function actually at the shop floor to be involved in this. We have received the model ICB blueprint, and you know it talks about making efficiencies, but I think what we've got to do is look to how we can support the function, ensuring that we are safe and meeting our statutory responsibility while supporting staff. And you know should note that staff morale within these functions, when they were clearly mentioned in a letter early in the year, it needs to be maintained. So there is work going on.
Thanks. Thanks, Chris. Chris, if I could just make a piece of information. Claire and I were at a meeting a workshop yesterday with the 9 DCSs, and they're going to hold a workshop looking at how we can improve collectively our work around SEND to target the most needy, to make it quicker, slicker, better. So let's make sure we're connected into that workshop. I think we are through Ellery. Is it Ellery?
Yes, unfortunately Chris couldn't attend, so she was going to come, but Ellery kindly came in off leave and attended that. So I was going to feed back to Chris, and I'm sure Ellery will. But Ellery has offered to help sort of establish the workshop, and it was a good conversation, I think.
It was a very positive conversation. The DCSs came up with a lot of solutions. So it was great. Yep.
What Chris has particularly outlined is in the NHS reforms there are a number of changes, so colleagues will be familiar, I'm repeating myself, but with Model ICB Blueprint of May, Model Region of the 8th of September, and 4 sets of guidance that came out on the 8th of September relating to transfers of duties for ICBs out either to region, to a trust or to an arrangement. So Chris has particularly talked about SEND and safeguarding, which we're referencing at the moment, but there's also meds management and all-age continuing healthcare. So it links with my Chief Exec's report from earlier. We are working to respond to that, and what Chris has shared is an example of what we're doing at the moment. We continue to carry the statutory duty until any legislation changes in line with NHS reforms, and therefore we're working with clinicians and our teams to make sure that we've got the appropriate resource available. And I just also want to put on record how warmly welcome the Directors of Children's Services across the system have been to me. I have become the Deputy Chair of the Merseyside Children's Safeguarding Board, which are very welcomed, and joined the first system oversight meeting very recently. But they are our support, they're our critical friends, and I support what you and Claire have shared about the ways in which they can help us find solutions as well. And I'd also note our Directors of Adult Social Services have also been supportive, and Andrew and Della's representative of local authorities. This is a key part of working together. But just want to reference particularly those 4 pieces of guidance that came out on the 8th of September for us as an ICB. Thank you.
Thanks, Cathy, really helpful. We're happy to move on. Let's go to Mike, Audit Committee.
Thank you. Just to pick up one point, the report does refer to an Appendix 1, which is the 24-25 Committee's annual report. I'm sorry that's not there. I'm sure you're desperate to read that report. It's a real page turner. But we approved that report. We talked about, we looked in depth at the risk register and considered there's probably the need for review reset. I think it's elsewhere on the agenda, but that's going to be future work of the Audit Committee to pick that up. There's just one area I just wanted to refer to specifically, and that we had a very interesting discussion about this topic of cyber security and how important it is, which led in turn to a broader discussion about the risk appetite of the board in this area, but by inference other areas. And I know we've already done some work on this, but this is a really important one. There's a self-assessment piece of work we've done against a new set of NHS standards. We're not green, but I don't think any organisation are rated green at this stage. And there's clearly an equation here that if you dedicate resource to this, you reduce the risk. If you have a lack of focus on it, lack of resources, it increases the risk. And the consequences of that risk can be pretty devastating. So it was a very interesting discussion, that, and probably links into some of the broader work we'll do with board members, but outside the formal environment of the board meeting. I'm happy to take questions on that or any other aspects of the report.
Thanks, Mike. Really important topic. Okay, let's move on. Erica, primary care.
Just want to reassure the board and our new FD, Andrea, that we're taking very seriously the pharmacy budget, the GP prescribing part of the pharmacy budget. Just to say, we've got a very unique committee where we have all the 4 contractor groups sitting in that. We've got the LMCs. Suzanne's coming, and I know the information is from yourself, Fiona, as well. It is a forensic deep dive on all the information we've got, and it really is down to GP level. We're not intending showing all that in the committee, but just so everyone is aware just how forensic it is. We're going to go through all the steps that are being taken, and then it's very much open to what more can we do and what more can we do with pace. So that is set for October. and we'll report back in November. And the only other quick one was to show how we continue to drive fairness and consistency. If you look on the paper, it mentions ADHD and also the weight loss, which is obviously out in the public a lot as well. So thank you.
Thanks, Erica. Any questions for Erica? Tony, Remcom.
Just a very brief, Chair. The one significant item was the committee's consideration of a request for a VSM pay uplift from an individual director. This followed on from an earlier decision the committee made not to approve the annual pay uplift for VSMs. This decision was set in the context of ensuring fairness, equity and affordability in our decision making. The decision was consistent with that made by the committee's previous meeting, where we decided not to apply the VSM uplift. So the request was denied. That's all from me, Chair.
Thank you. Any questions for Tony? No, thank you. Going to the chair of the Children's and Young People's Committee. That's me. Take the opportunity to say I'd be really, really disappointed if we don't carry on the focus on children and young people. If you do have a chance, have a look at the single line of sight report that supports this committee. But the last one, you will see some remarkable progress happening, things happening in full partnership across our system, and some of the outcome dials for our children and young people starting to move. It's one of those committees I look forward to going to, and it brings me great joy, not least that there can be 2, 3, sometimes 4 young people sat around the table holding us to account, and they're very good at that. So please do your best on that. But happy to take any other questions. Okay, thank you. Ruth.
Thank you, Chair. To alert you to the situation with the model region, and to ask you to note that they will create an Office of the Pan ICB Commissioning, which will be hosted by one of the ICBs in the region. The team are flagging obviously quite a lot of risk in terms of all the transition and clarity about who's responsible for what and so on. But just to alert you to, that's the latest that the committee was informed about. I wanted to highlight that the Joint Committee, through its delegated authority, made decisions about funding of mental health lead provider collaboratives, which are detailed on the 3rd page of the report, which I won't go into detail. It also, but I will come back to it when I finish, before I finish. Also to highlight that the work that's ongoing in reviewing neonatal services, the public engagement process, excuse me, will commence in October. So to be aware of that. And there were other decisions made about a selection process for a very specialised orthopaedic service. I won't go through everything. The committee also reviews a block of the Pan ICB services to look at what transformation's happening, what the issues might be, and so on. And on this occasion, we looked at specialised medical services, general medicine type services, but in the specialised space. And the team there were very keen that as an ICB, we realised that if we concentrate on prevention in cardiac, renal and metabolic diseases, we could 40% of the specialised workload is preventable. If we did more in the diabetes, heart disease, renal disease space. So it was quite a strong message, lots of analysis to support that assertion, and I really think as we go forward and Andrew wrestles with the next 3 years financial budget, we really do need to think about how we get ahead of this, and we've talked about it many times, but it really was very stark. So I want to come back to the decision that was made to fund various mental health services as lead provider collaboratives, and I'm going to ask Claire to update us on information that came to the executives after we'd made the decisions. And Claire, could you explain the situation?
I'll try. So the decisions were made using the information at the time, and it was a joint committee conversation. I think it was literally 2 or 3 days later that the new segmentation sort of scores came out, and 2 of the providers that had been awarded lead provider collaborative status, one in Cheshire and Merseyside and one in South Cumbria, had been put into segment 4. So we were seeking clarity from the specialised commissioning team whether the decision made at joint committee still stood, or whether the segmentation 4 sort of precluded the providers from taking on that responsibility on behalf of the population. I've got an email here in front of me, which I won't read from, but I think both Ruth and myself would probably seek greater assurance from the regional team and the national team that the decisions can still stand. We are advised they can from the Deputy Director of Specialist Mental Health, Learning, Disability and Autism in the national team, and from the Regional Director of Commissioning. But I think in terms of being absolutely sure and for assuring the board, I'll go away and do a bit more homework. I'll speak with Ruth and we'll do an email out to board. So I think we will say it stands at the moment, but with the caveat that we're just seeking absolute assurance that that decision made at joint committee is allowed to stand. If not, we'll have to either do an extraordinary joint committee or wait till the next meeting, which will be in November. But it was just to bring that to the board. Literally, it was within a couple of days. And the problem is, I think Anthony will say this, the segments change on a regular, and that's one of the challenges, that as every quarter, so it could be that next quarter they're both in segment 3, which is okay, but it could change. So we just need that assurance from the national team, and actually probably from Louise herself, from the regional team, just to sort of be assured for the population.
That's my recommendation, is that the committee concluded their decision on the basis of probably 12 months' work by the specialised commissioning team, which is in the regional team. And they advised us and guided us through that decision-making process. So this is a sort of change of rules after the decision was made. But obviously, given the scrutiny that all ICBs in the North West are under, we need to be satisfied that somebody isn't going to turn around and say that wasn't the right decision, basically. So we want assurance that, based on the fact the team guided us through 12 months of their due diligence and assessment of the situation, and we acted according to their advice. So it was just a flag up that we may be being overly cautious, but if the rules did change just after we'd made that decision, and we need to be clear that we're on the right ground.
Trish?
Just checking, if I may, Chair, have providers been informed of the decision?
We wouldn't have, the ICB wouldn't have informed the providers. It would have been a specialised commissioning team if they had. And I'm taken by your question that you haven't been.
No.
Okay, I'll follow that up as well. Considering the decision was made, it was the first week of September because I was on leave, but that's 3 weeks ago or so. So I'll follow that up as well.
I understood the process, it would be after we'd considered it and confirmed it.
Okay.
So I understood it was the 1st of October, so there was some, so that's why we need to be absolutely clear the decision does stand before the 1st of October.
Okay, that's next week, so I'll do that tomorrow or Monday. Thank you.
Let me just check with everybody that people are happy with that level of risk appetite. Basically, we've got a really low one on this. Let's make sure we're not operating a ultra vires decision, whatever the right phrase is, and we need to wait until we've got that confirmation.
Yep, I'll follow that up tomorrow.
Okay.
With Andrew and the regional, excuse me, Andrew and the regional team, but we might want to escalate it because and they did confirm through the Director of Commissioning at the region, but I think in light of everything else going on, we probably just want to sort of bells belts and braces on this one. Thank you.
Thank you. Hilary.
Thank you. Just a reminder that in
Sorry,
March...
sorry, Hilary. Mike? Yes. Sorry, I didn't check. Go ahead. Oh, sorry.
Am I on now? Great, good. Just winding back, just to remind people that in March we approved the a process for examining the options for the future maternity gynecological services across the Liverpool City region, and it was that process that took place over the spring and summer and involved users with lived experience, a range of clinicians and obviously our stakeholder groups in workshop that resulted in some options of how services could look like in the future. As you'll sense from this is a range of options that are now being worked through. It's really detailed work, and there's been a Merseyside internal audit are helping us as well as our clinicians as well in relation to what this means in terms of areas like workforce, buildings and obviously finance. It's really detailed work, as I said. So we understand what the detail underlining the options. It's taken a bit longer than we originally planned because of the complexity, but we hope to bring those options back to the board in November. And there's no further risks added to the risk register. Just to sort of state the obvious, really, that no decisions have been made in relation to the future services in the city at this point.
Thank you, Hilary. Any questions or comments? Thank you.
Sorry, Raj, my questions were on the previous paper.
Oh, sorry.
That's why I got confused.
Go on.
Could I just check this off-pick? Does it confer any advantage to us to host it, or not? What's the process to decide, and are we going to express interest in it? And I've got a second question. The unpicking of the block arrangements on specialised commissioning implies we might be going back to some form of volume-related contracts, and as I remember, pre-block, that was a budget which always overspent. So does that create a risk for us in the future?
So just in terms of the first one, I think from a SpecCom perspective, we are let me get this right. We spend more than our allocation in terms of our fair shares. So we need to reduce our fair shares over a period of time, and that's been agreed between ourselves and the Specialist Commissioning Team at the region. So that's the first one. In terms of off-pick, so this is a long time. We've been working with the Specialised Commissioning Team and the other two systems probably for a couple of years now, and we were looking for Langston South Cumbria. We're going to host the Specialised Commissioning Team from April next year, which had been delayed a year from this April. This is a national change, and it's outlined in the regional blueprint, which will cover off specialised commissioning team and all of the other direct commissioning functions, so 7A, health and justice, and a number of other functions which we had hoped would come into sort of the authority of ICBs from next year, but nationally it's been determined that there'll be this sort of office which will sit with NHS England till at least April 27. It will then transfer to a host ICB. I think currently the thinking is that it should all stay together for efficiencies, and because otherwise you're sort of splitting up the commissioning teams that sit within the North West region. I think there is an assumption that it sits with Langston South Cumbria because specialised commissioning team, we're going to sit there, but that hasn't been agreed, and it may look very different because I don't think we really know what it's going to look like, because we had thought at one point that we might look to host the sort of the 7A services and sort of IMS and screening and that side of thing, but if they're going to keep it all together, we need to look at sort of efficiencies, how the team works together, but how we get best value for the population. So at the moment, it stays within as a sort of within the Northwest region till April 27 at the earliest.
Thanks, Claire. I would suggest you keep this on the agenda somewhere in a timely fashion, because there can be advantages to hosting and leading services like this, as well as the potential risk. So let's make sure that decision just doesn't fall out.
I'm sure there'll probably be a process, not a sort of a formal, tendering process, but I think between the three ICBs in the region, there'll be a process or some sort of conversations. But yeah, even though North Lancashire and South Cumbria are looking at it for SpecCom, this is much bigger. This is the whole direct commissioning team.
Thanks, Claire. Are we happy to move on? Fiona?
Thank you, Chair. Matthew, where do I point this to make something happen? To my left, like that. Lovely. Thank you. So, board will be very familiar. We've just walked through with Anthony the integrated performance report, measuring our key metrics on urgent and emergency care. But the board had asked for a more in-depth look at, so what are we doing to turn the dial on those metrics, and what's happening across the system. So that's the purpose of what I'm going to talk about now. I'm going to just want to provide some assurance, first of all, on how we are organising ourselves and governing the work for this. That's our wiring diagram. What we have set up that's new is, and Mandy isn't here today, although I'm for good reason, but I'm sure she would want to talk herself a little bit about the review and recovery meeting. So this is a weekly meeting. So it's a big meeting. We've got COOs, directors of nursing, medical directors from all of our provider trusts, and Mandy brings them together and really grills them on things like the 4-hour performance, 12-hour performance, non-criteria to reside ambulance handover. So the sort of the real chunky metrics that we tend to worry about. We have a new or a refreshed UEC improvement group, which I am now chairing. And the purpose of that is to give us the ability to take a step back and look at our programmes in a bit more detail. Are the things that we are doing making a difference, not just this week, but in the long run? And also it gives us the opportunity to and you'd expect me to say this, to foster that improvement culture and drive a consistent improvement approach, because we know how much evidence there is to support that approach. And then Mandy's also put in place the UEC Improvement Board, which is a monthly meeting focused on the strategy, oversight and assurance, and that is attended by our directors of adult social services, representing, so not every single one of them, but representing the sector. We have its chief executive level, there is chief operating officers, there's medical directors, we have NWAS in that meeting as well. And so that is supported, it aligns with 3 other pieces of work. So FCOG, which Mandy chairs, which is looking at the financial elements of UEC, and Anthony's work on winter planning. And then crucially, this new tiering approach that the region are responsible for. And I would say it's still a work in progress with Sam James, the Director of Performance at the region, about how we make sure that what we're doing isn't duplicating what they're doing, and that we're not asking providers to report repeatedly on the same things. The next slides, I'm not going to go into in detail, they're in the pack in order to give you a sense of the continuous improvement approach that I'm really keen that we put in across our programmes of work. So it's the aims of the improvement group, it's the way that we're going to organise ourselves with that split between looking at performance, looking at our metrics and how we're doing over time, but also spending dedicated time on the cultural piece that supports the major service changes that we're doing across the UEC system, making sure that we've got the right behaviours, that we've got the right capability, and that we can sustain any changes, and that we share the learning. And we want that to be very much a learning environment that shares best practice. And I have some really, really keen improvement colleagues in the system who really want to do these sorts of activities that build a bit of energy around change, and rather than it feeling, as it can sometimes do with UEC, that we're just all getting beaten to do better, we actually celebrate some of the really good work that we're doing. So there is, I could have put in about 20 slides that list the vast range of work streams and projects that are happening in UEC improvement. What I've done instead is just put in our two main driver diagrams, one for the system generally, that is trying to address our aim of reducing corridor care by 50% by March next year, and deliver our performance improvements in line with the UEC plans, as well as considering value for money, and then replicated for the mental health system. You can see from the driver diagram that we break it down into pre-hospital, so admission avoidance, in-hospital activities for flow and discharge, and we do that across 5 localities. So not 9 places. The localities are based around the UEC flows. So for example, we use North Mersey because the populations of Sefton, most of Knowsley and Liverpool all focus round Luft as their UEC provider. So those 5 localities have got some projects that are common to all. So in-hospital flow is the same in every hospital, the Safer Care Flow Bundle, things like boarding, consistent ward round and board round processes, that Safer Patient Flow Bundle. And some that are bespoke to the local area because they have a particular issue in that area that needs a dedicated piece of work. And the element that is focused on both admission avoidance but significantly discharge is very much done in an integrated way with our local authority teams as well. We then have some pieces of work that are cross Cheshire and Merseyside. So example of that would be standardisation of our UTC offer or our and our WIC offer, our frailty plan, our virtual wards. What we realised over the last 12 months is that we were doing these on a locality basis, and there was a lot of duplication happening and several people working on the same thing and in a little bit of a silo. So we've now lifted that up and we do them across a Cheshire and Mersey level with SROs, and that reports into our improvement group as well. We had Rowan led a recent risk summit, which was bringing together different parts of the system to consider how we share the risk in the UEC system across the whole pathway. Last year, and particularly the winter before, NWAS would tell you that it very much felt like they were carrying all of the risk. Patients were waiting a long time at home for an ambulance, and they didn't feel that the hospital was owning that risk. The A&E departments would tell you that the wards doesn't feel like they own that risk as well. So the intention of the risk summit was to challenge that. So one of the pieces of work that came out of that successful summit was a focus and a new work stream on criteria-led discharge, which is something that we'll take forward now over the next few months, hopefully quite rapidly, Rowan, before we get into winter. I've included in the pack a summary of our frailty plan. This is an example of where there was lots of really good pockets of work being done across the patch, but we've now brought it together into quite a detailed plan so that we can really share expertise, learning, etc., and trying to drive some consistency. It's very much aligned to the national NHS impact work, which has funded something called Learning and Improvement Networks on a regional footprint. So we have the Northwest LIN that has 3 work streams: UEC, mental health and elective. The LIN chose under their UEC group to focus on frailty, and so it was timely that we match that, and it's very much aligned to the work that they are doing. They are building some communities of practice. They've got some teams that they've looked for expressions of interest, and we've put forward our North Mersey frailty team for some additional support from Aqua. Our North Mersey team are quite well advanced in being all parts of the system coming together to look at frailty. So they're going to benefit from that additional support. And then through the UEC Improvement Group, we will be asking them to then share that across the rest of Cheshire and Merseyside. So what do we do if we think that our plans are not working? And this is an example. This is anonymized and not necessarily you wouldn't be able to identify which trust this is from, but we received a good challenge from our regional colleagues at one of our assurance meetings recently about how are we tracking whether the things that we are doing, the programs of work that we've got in place, are actually making a difference. Now, the regional team are particularly interested in that 4-hour, 12-hour metric. So this is how we're going to track it, and both at the UEC Improvement Group, we will have a view of this, and it will be discussed at the UEC board as well. But Mandy is very much holding providers' feet to the fire on this in the weekly meeting as well. And where providers are off trajectory for achieving this, they have been asked for detailed recovery plans that answering that question of what are you going to do, by when, how is it going to turn the dial on those metrics. So that is an example. We asked our providers to, and I will name this one. This one comes from Warrington Trust, because we thought it was an example of really good practice, the way that they'd set it out. They'd also done a very nice waterfall chart to show us how they were going to meet this recovery plan. So we've shared that with the other providers and asked them to do their recovery plans in the same way. Sometimes it can feel a little bit like everything's doom and gloom in the UEC system, and I am not for 1 minute pretending that there aren't problems. And we heard from Leslie at the start of this meeting about a patient today who is still experiencing suboptimal care in one of our hospitals. However, I did want to show that we are making some progress across Cheshire and Merseyside. So for our overarching aim of corridor care, we have seen progress in the last 12 months, and particularly wanted to demonstrate 2 of our providers that have significantly improved on this metric. And they've done it in slightly different ways, and this is the bespoke nature of their improvement plans. So for Countess, they did some physical rearranging of their space that gave them more space in the A&E department so that they could offload ambulances better. They had more assessment space, and this allowed them to be more efficient. And I mean, you can see from there that is a really significant improvement. Luft did it in a slightly different way by changing their systems and processes, and it was very much about the safer flow bundle. They introduced really rigorous boarding where patients were moved more rapidly out of the A&E department onto the wards. Both sets of actions leading to an improvement. I'd put in the handover 45, it's just a really nice demonstration. I won't repeat what Anthony said, But this, the only thing I would say about this is the morale improvement that has come out across the system from being able to demonstrate how this is working has been not insignificant, and the benefit to the working relationships between our NWAS crews and the system colleagues has been really positive as well. A couple more examples of where we are making some improvements, and then I wanted to sort of attribute this positivity to the provider collaborative, so particularly the community arm of the provider collaborative. This time last year, if an ambulance crew, as they often found themselves out of their familiar area because they've been called, they're normally based in Southport, but they've found themselves in Warrington, they've got themselves a patient who they think really doesn't need to go into hospital, but because they weren't in their local patch, they didn't know who to phone, so they would just take them to the A&E. What the Provider Collaborative has done is put in a single point of access, so it doesn't matter where the crew is in the system, they ring the same number. And that single point of access puts them in touch with the urgent care team for that area. And you can see there that since that was introduced, the number of calls, so the crews are taking this offer up, the number of calls is increasing, and then the number of people who are being transferred through to the UCR is going up. And that is then, we're seeing the number of admissions from care homes starting to go down. Mandy is pushing them even harder on this though, because she wants to see every single category 3 ambulance call being put through this system, which is a challenge. And just to finish, I as I mentioned, it can be negative. I don't want people to think I'm glossing over it. I've included our variable performance on 4-hour and 12-hour performance there as well. But overall, I think we have got the right things on our to-do list. I think we are now better able to track them and to challenge ourselves in the system to go further and to go faster, and critically to share what they are learning as they do it. And we are looking to reallocate resources from within the ICB to support this work as well, which is very positive. Thank you.
Thank you, Fiona. Any questions or comments? Some really good stuff. Ruth?
Yeah, great. I mean, this is what we need to see happening. Pardon?
I'm hoping it's what you asked for.
Definitely. One point of clarification I wanted to ask, which is when you're engaging clinicians on this agenda of urgent emergency care, are you getting full cooperation and engagement from surgical services, orthopaedic services? It's not just focused on, if you like, the general medical take, because obviously where falls, for instance, are concerned, they could have had a fractured hip and had all the rest of it. So just reassurance that we're looking across the whole of the urgent care pathway. That's my first question, and then I've got my second point, it's more of a point really. Don Berwick, who many of you know is the guru of quality improvement, he did a piece of work some years ago now. It was in the US and asked for people to say what their rules were that got in the way and called them silly rules. And I guess, how close are we to the front line to identify the things that are probably not in the regulatory process? They're just things that have got in the way of grown up over the years, and are we able to identify those? And I'll give you one which may not be in the category of a silly rule, but I was approached by someone who's dissatisfied with services in this conurbation to tell me that the individual had a fracture, neck of femur, kept in hospital. Because they were not resident in this area, they had to have a temporary GP, and the family couldn't get one. Nobody wanted to take the person on, so they stayed in hospital. So that, for me, it's not a silly rule, but it's an obstacle in the system. So how close are we to identifying the things that are really stopping things happening, I suppose? So they're my two questions, comments.
Two very good questions. Thank you.
the question about how engaged are this, let's call them the specialty teams, because I think I would say the acute medics and the ED medics are obviously very engaged in this. I've picked up, and I haven't actually, literally in the last week, I've picked up a piece of work that Greater Manchester did, well, Manchester Foundation Trust did, where they have written some rules of engagement, if you like, some best practice, some, I can't remember the title that they used, but it speaks exactly to this, to get rid of that bounce, and I am looking to, I'm going to share it with our Trust Medical Directors, because I think we're probably not quite there yet, and whether Rowan wants to comment on that from the perspective of being one of those specialty doctors.
So everywhere I go, I'm engaging on exactly that on the ED visits. And indeed, I'm hearing some mixed pictures of where things work well, but we've absolutely taken silly rules out. So one of our trusts that I happen to know quite well had what we would term a silly rule, that even when a consultant from the emergency department with 20 years experience had put their hands on the belly of a patient and said, I think this is a sick belly, this needs a CT scan and a surgeon, the standard operating procedure said they need to be seen by a member of the surgical team first, which could be the SHO, with 4 months experience before they could have a CT scan done, which I would suggest is in that realm of silly rules. So acute abdomen pathway says anybody can order a CT, because that's what's going to be demanded, short of someone in a crashing, life-threatening, we've got to get into the belly now situation. And that's exactly what was instituted now almost 2 years ago. So taking that everywhere. There are still challenges around getting blocks into fractured neck of femur patients, getting them moved up to wards and bits and pieces like that. I do believe our surgical specialties are well engaged, and speaking very personally, having our own trauma unit means we move urgent plastic surgery trauma immediately out of the ED. But we need to assure ourselves that such practice is being replicated everywhere.
Your second question, thank you for referencing Dawn, hero. I think there's more we could do here. I'm speaking to each of our places has got a GP clinical director, and we've got some GP leads. I'm asking them next week to redirect those GP resources into some more of those frontline conversations. They are happening, but they are not happening enough, I would say. But it is the advantage of having locality-based approach to this, so that you can get those local, and we can use our primary secondary care interface meetings as well for that.
That's helpful. I think sometimes it's put on the onus on the family to find that solution, and without support, and if you're not familiar with how to find a GP easily,
that one just sounds bizarre.
So there's something about how do we help people problem solve in that situation.
Yeah.
I mean, I only use that because it's been raised with me as a concern. And I realise why they needed a temporary GP. That isn't a silly point. They did need one. But it just illustrates there are little things in the system, relatively small things, that do get in the way every day. And how do we really get on top of some of those? But thank you. It's good work.
Thanks, Ruth. Naomi?
So I think in answering Ruth's question, you've probably also answered mine, which was going to be what are the communication channels with general practice and primary care. I think we do need to find a balance between, often general practice feel that they are asked to either increase seeing patients or asked to kind of solve the A&E problem when actually GPs are already at full capacity. However, having said that, there are things that we can do in general practice that can aid. If we know that things are escalating, particularly around A&E attendances, we're able to do things like we can alter the number of acute on the day appointments versus the number of long-term condition appointments. There are things that we can alter and that we can assist with that. I think the other point was again around communication channels. So I had an interesting case last week where I was contacted by a paramedic who was asking me regarding a patient who had recurrent falls and asked me to refer on to a falls clinic. If I could have given that paramedic a medal there and then, I would have done, because that was an excellent example of joined up care and joined up working, but that doesn't always happen. We've things like, I know you've said about different paramedics working in different areas, but I had a paramedic ringing me asking me to do a referral through to ICRAS, which is one of the care at home services, and it's the acute care at home service in Liverpool. Now they could have done that referral themselves. So it's just, I think it's just standardising the approach across the whole area, but also, you know, general practice are part of the wider system, so we can help support when things are deteriorating.
Thanks, Diary. Some really important points, good observations. Question for me, Fiona, and what I'm not trying to do is load more stuff in. It's an observation, and Paul, it's going to be relevant to Health Watch. The indicators we track are also proxies for patients' experience, but they're not the totality of the patient's experience. And some of those little rules, is that what you call them? Whatever. Silly rules. You can hear them through the patient's voice. And in the past, Health Watch's reviews of EDs have brought a lot of that out. Is Health Watch engaged? So do we hear the patient voice in your work?
You'll recall Louise spoke to the board, didn't she, from our own personal experience. I think it was last year,
yes.
and I know Health Watch do their visits. I would say that is an area that we could join up better on.
Okay. Thanks for it. Paul,
just to say, absolutely, we would welcome that as a piece of work. I think it's activities that we've undertaken in terms of entering views to A&E across the Cheshire and Merseyside patch over a number of years. I think we'd be willing to contribute again on that.
Thanks, Paul. And I'm going to admit to embarrassing myself by asking Don to sign my book, Crossing the Quality Column. So I've still got that. Right, that was good. Very positive stuff, Fiona. Thank you very much, and all colleagues who are leading on that.
Rose, can I just put a comment? Just to share that Fiona, with Anthony Middleton and Mandy Nagra, presented a version of this at the monthly oversight meeting we have with NHS England North West regions. So since June this year, we've had a monthly meeting rather than a quarterly meeting due to the need to improve NHS performance and financial recovery. And this presentation and this work, and backed by metrics, literally for this month, this financial year and into next year, provided good levels of assurance to the regional director and her team. So this is back on the agenda for our next monthly meeting on the 1st of October alongside electives work. But I just wanted to, this is not the only forum where this is being presented and providing good levels of assurance. And thanks to Anthony, Fiona, Mandy and others for working on this, particularly our colleagues in places.
Yeah. Useful, Cathy, thank you. Anthony, can we go to winter planning?
Yes, thank you, Chairman. So it's not my normal style to have board papers that are as long as this, but I think in the interest of transparency in the subject matter, I think it's worthy of many of the inclusions of the appendices that you see. The paper summarises the planning and assurance activities over the summer and asks formally for the board to consider and approve the recommended submission to NHSE, which is due at the end of this month. It's no coincidence that Fiona's report on the improvement programme went before this, because I would remind the board that the winter plans are not intended to be an exhaustive list of additional schemes to mitigate the increased seasonal pressures. Indeed, for the second year in succession, there are no centrally provided winter plan monies available from NHS England. The change in emphasis has been that the plan is about preparation, resilience and response during the period of heightened pressure, particularly through the lens of governance and oversight. And therefore we've approached the development of our plans as we would do for any planned major event, with a high degree of focus on learning from the previous winter period, where a number of our local systems did indeed declare critical incident status. So through section 4.4 you will see the approach as used at the design, which Fiona's already talked about, in terms of the governance of the 4 localities, as well as some cross-cutting themes with a list of subject matter experts, for example vaccination and Ian's team. We've been through a process where there have been 2 cuts of the plans so far. The first, which received initial ICB and NHSE feedback, and the second, which was subject to check and challenge in the past 2 weeks, performed by the ICB in the light of the learning from Exercise Aegis. Exercise Aegis is a regionally led but national approach to the testing of governance escalation and system responses, and we had an exceptionally large turnout from that event. Just as a similar cross-reference, it should be noted that all NHS providers have been asked to sign off their own particular assurance statements. Those boards have been meeting this week, and I've had no reports of nil sign-off thus far. In terms of the output, whilst the localities have had free rein to develop winter plan documentation by their own design, we've given a very clear instruction to ensure that it utilises the ICB developed winter plan checklist, and that each locality adopts the practice of consideration and sign-off of the assurance statement as if it was indeed an IC board standalone. And that's displayed at section B of the papers. It does go into some level of detail, but you can see within that what is the current RAG rating against each of the checklists. And again, those locality boards have been meeting over the course of this week with a view to signing off their own assurance statements. You can see within the paper there is a high-level summary at 5.6. I guess in trying to summate it, I would say that, you know, from everything that we've been through thus far, I think each system was able to evidence clear joint development across all sectors. I would particularly pay praise to the DASs, who have been really proactive in working with us on this, recognising some of the challenges last year, the inherent drop in discharges between Christmas and New Year, and the bounce back into January. I think I would point to well-developed and mobilised preparation, including the focus on vaccination and the scheduling of multi-agency discharge events ahead of the Christmas period, which are already put in train. Some systems actually doing two phases during November and December. I would point to a strong governance and oversight with a clear understanding of triggers and roles during escalation. And if you look at Appendix 3 at the back of the paper, that absolutely sets out the roles and responsibilities for each of our system partners, absolutely linked to the level of escalation which we draw from the system 4 times a day. I think there was absolutely strongly featured learning from previous years, particularly in those organisations that did declare critical incidents. And there is clearly identified risks, which at the moment is focused primarily around 7-day and Christmas period services. But as I've said, you know, mitigations put in place to try and smooth that flow during that period. There are still gaps in the plans, you can see that yourself, but absolutely, you know, a continued process to address those as we move through the next few months. The plans have been submitted and subject to ICB quality and equality assessment last week, and Chris and Rowan may wish to contribute as we near the end of this paper. And therefore, I guess in formality, I would recommend to the board that the plan should be approved for submission, as the elements within section A, which is the criteria, are all evident. But I would emphasise that this is not the end point of development. You know, there are at least 2 further months before the demand will begin to rise, and therefore we have absolute assurance that locality plans will be continually developed to address the current gaps, and it will be overseen by the locality boards. I'm suggesting that further assurance on progress will be provided through the Quality and Performance Committee of the ICB, and in turn back to the board, which should be required. NHSC have stepped up their own assurance process through the establishment of a weekly session where we have been as transparent as we have with yourselves in terms of where the gaps are, and I will represent Cheshire and Merseyside ICB in those weekly calls alongside my counterparts at Greater Manchester and Lancs and Cumbria, as we work to not only address our own gaps but learn from each other in good practice. And just as a last level of assurance, we are taking both the improvement plan and the winter plan to the Joint Health Oversight Committee on the 3rd of October. Again, I think that's a really helpful, proactive approach by that committee. It would normally be the pattern that I would attend that committee in April to talk about how we manage the previous winter period, whereas this year is very much about, can you bring us the plan in advance, and how can we help assist you identify and plug any gaps. So that discussion will be taking place next Friday. So I'll end there, Chairman, and welcome the debate.
Thank you, Anthony. Rowan?
So, as is demanded, the winter plan comes to a quality, the QIA panel to review. And in truth, the plan would not have reached the threshold for a QIA panel review, because the plan in and of itself does not disadvantage our patients. It's winter that disadvantages our patients, and we were not asked to do a quality impact assessment of winter, which would be dire, but a quality impact assessment of the plan. So the plan in and of itself does not disadvantage our patients. In fact, largely quite the contrary. There is some risk in there around delivery because of workforce and our ability to resource that workforce at times of challenge, and wanting to use far less agency staff and all the rest of it. But the plan in and of itself is straightforward from a QIA point of view. So to assure board, the most important part, having moved through that, and it was an interesting debate that we had, is that the plan itself must be stress tested or undergo stress testing to make sure it will stand up to the challenges of winter, which is a separate process that Anthony and colleagues have gone through outside any sort of quality impact assessment. So that was relatively straightforward, but we must highlight the challenge to make sure that we can resource, if we are under huge pressure and needing to have beds on corridors, that we can resource a workforce to support that. Thank you.
Thanks for that. I suspect Ruth and I might have the same comment to make on. I guess I don't understand the rationale for why the plan doesn't need an assessment, because if you have a plan, it's describing an action, which is a change from what we do, and that normally would mean you need an assessment.
Absolutely. So let me be clear, it's not that we didn't assess it, but the plan in and of itself, i.e. most often things that come through quality impact assessment are saying we're going to change this service, and what will this do to the service users, and will they be disadvantaged if you are changing that service. This plan moved relatively smoothly through because every element of it is about improving the quality of care to those who are labouring under the effects of winter. Winter is what does poor things to people rather than the plan itself.
Ruth,
I mean, please, because we debated this at length. It has to be said.
I'll come at it from a different angle, but I think it's in the same territory. So I was interested to see that you've done demand modelling. There's a lot in here about we'll have gold command, silver command, and all the rest of it. That's just process of communication. The key to managing winter is what can you mobilise when the crisis is coming, before it comes and when it's there. So I see that you've done demand modelling, or there's some ambers around some of that. So my question was, have we identified the range of interventions and capacity that can be mobilised at different levels of escalation? Because at that point, you are maybe stopping electives. You might be doing other things, which do have impact assessments that need to be considered. But for the Gold Commander, and what I would want to know is, what's the surge model that we've modelled? How far can we go? And when do we get to really difficult, serious triggers of having to mobilise different interventions? I have no sense from this about which winter have we modelled. Have we looked at the last 10? Have we looked at the COVID years? You know, what are we modelling? And how confident can we be as an ICB that whatever comes our way, the deepest, coldest winter, the worst flu, that we've ever had, how far can we go? What's the potential that we can cope with? I have no sense of that from the winter plan.
Yeah, so Ruth, it's impossible to mitigate completely about obviously the winter period. But in terms of what we've done is we have approached it from our experience of previous winters, where we absolutely understand the pattern of demand, and we have put steps in place to try and mitigate against it. So, for example, we all know that the acute sector will have the highest level of discharge on the Friday before Christmas. But that capacity in terms of discharge will slow down between the Christmas and New Year period, and by the time you probably hit the 2nd of January, you're full again. So therefore the mitigations have been put in place to try and decompress the hospital ahead of that Friday, and then also steps have been put in place to maintain some level of discharge through the intervening period, and that the response and oversight of all those operational and clinical teams has taken account of that in the first week in January, so that there are proactive taking down of elective programmes, because we've got ourselves ahead of the game and we will shift it. The OPAL score sheet on the back is replicated within each provider to say what are the steps that you take when you hit a certain level of operational level. So one of the things that we learned from last year was we had a much swifter response to some actions such as boarding on wards because of the learning from the previous year, where actually we waited 24 hours to decide who was having it the worst. Was ambulances under the most pressure? Was A&E under the most pressure? Where are we managing that risks? And there are clear works that Chris did last winter, ahead of winter, which then received national applaud, which says when you get to this level, you invoke boarding. When you've invoked boarding, you've already taken down your elective programme, and we have that level of granularity from each for the 5 systems. I've not brought it here, and maybe it would have benefited if I had, but we have seen evidence of those exact events and the response that's necessary.
Thank you. I mean, I'm very familiar with the whole Christmas scenario.
I know, yeah, absolutely.
I used to do that, you know, when I was running stuff in Liverpool. I think it's more about the big picture of, you know, if the whole system's under pressure, what's our tolerances. It'd just be helpful to have a sense of how much can you release by taking all these steps. Have we got a big picture understanding that could give us some assurance that we can cope with quite a bit? And that's what I'm not getting from the plan itself. Yes, we've got actions we can take, but have the senior commanders, gold commanders, got the tools in their toolkit to be able to actually respond effectively? And it sounds like you're learning from each year, but as a board, looking at the whole strategy of the system, that's what I was looking for, was, you know, what's the big picture assurance we can get here on the capacity and demand model? Thank you.
It's a good challenge, isn't it, Anthony and Rowan? And I've seen work elsewhere where that question is answered through quite extensive simulation modelling of existing systems. We haven't got that, I don't think, unless you've hidden it under your bushel somewhere. So we're looking for proxies really for that type of analysis that could help us as a board understand what that additional capacity and what the interdependencies are as we go through the OPAL levels. I think that's what the best that we could do at this moment in time. I've got Andrea and then Warren.
Thank you. Just a question around the plan, particularly when you're looking at capacity and flow. Has the plan been costed, and do we know if any costs are already within provider forecasts?
I think there are no additional costs built into the plan. No one's putting anything in additional. I think the risk there is where under a certain level of escalation, people may be pushing to open up additional capacity. That's the risk, and one that we know featured even in the conversation with PwC and Luft yesterday. But at this point in time, there's nothing that's been built in as an additional scheme. It is very much around the response, but getting ahead of yourself to smooth the flow, buy the capacity down to 92% ahead of Christmas. And that's one of the triggers. As occupancy rises, triggers rise in terms of response times. That's the bit that triggers a further response further along. But it is about making use of the capacity that already exists and the strength of the improvement plan to put us in the best possible position before we go into Christmas.
So let me come to Kathy. Andrea, I think we'd be comfortable to put some sort of contingency or risk into our finances for the winter period, because I've not known a winter where there hasn't been an escalation into extra costs. So back across the system, we need to have that, I think, if it's not already built in. Kathy?
Thank you. I mean, we every winter is difficult, we're also running a winter in financial recovery and turnaround status. So what Anthony is referencing there is that we need to work with the existing capacity. We are not expecting any additional funding from NHS England / Department of Health and Social Care, and we need to work with the capacity that we have. Anthony and I have spent some time together in talking through these plans. He's presented them through to our executive committee with colleagues as well. We know there's learning year on year. We want to take this through to region as well to give them assurance. And there's more support this year, I suppose, in reflecting on NHS England, particularly a North West event that's taken place. One of the pleas from trust providers is around working with local authorities on care packages and the pace of those, and I'm sure there'll be pleas also from local authority, particularly social care, on ways of working with parts or all of the NHS as well. So we need to make sure the whole system works connected together. So I'm saying obvious things, Raj, but there is a reality of working within the existing capacity that we have at the moment with the expectation of no further funding. So we need to work out what our local contingency will be.
Thank you. We've got Warren and then Naomi.
Thank you, Chair. It was just to pick up on, and thank you for all the work you've done on this. I know it's been a huge piece of work at great pace. Just picking up on the line in 5.8 around VC FSC sector and the need for more work to be done to engage the sector as part of it. I'd be happy to support that if that's useful.
Thank you, Warren. Naomi?
I think just to reiterate the point that the risk analysis needs to be across the whole system, and the cost analysis needs to be across the whole system, and that includes not just general practice but the likes of pharmacy. If we are being asked to provide additional capacity, then that needs to be appropriately resourced.
Good point, Naomi. Thank you. Rowan?
So I think from listening to the debate that we've had, particularly if we're not expecting to put that resource in, but we know some of the most expensive parts of our hospitals we run are corridors, that it would be really helpful, and I will take this away with Anthony and indeed Fiona, because of the improvement role in UEC, to go through the stress test of that plan, look at those escalation points, what surge capacity looks like and how it's resourced, so that we can assure ourselves of the ability to flex in response to what happens. We know when it happens, and that capacity needs to be there to step in. Because if indeed what we're saying is there is no more money to spend, then that will mean taking down electives, and that will have a quality impact if you're the person waiting to have your elective surgery, which wasn't what came through that other process. So we will take away to that further clinical review of the stress test of the plan and see whether it influences quality impact. Thank you.
Thanks, Rowan. We need to get to the recommendation here about supporting the board statement or not. But before we do, I'm just going to pick out one to the North Mersey dashboard, and it's about 7-day discharge profiles. And what does profiles mean? I don't know it in that context. And
so, and we picked this up with North Mersey last week. Really, I think they've been very stringent in their RAG rating. 7-day discharges for Luft is more prominent in terms of, you see a drop in discharges at the weekend more than any other provider that we see across Cheshire and Mersey, and they've picked that up in that as part of their winter plan. It's crossing over into the general UEC improvement plan at that point in time, but nevertheless they had tagged it as red when we met them last week. They are reviewing and getting further evidence of that this week. They believe that they can shift that to amber at their discussion tomorrow. But I guess this is the reason why it's in, is because that was at a point in time. It will still be moved on. But for me, that is more about you're trying to use a winter plan to address what is an inherent improvement programme that's prevalent there for North Mersey. But I think it's a good example of the level of transparency we're trying to give to the board as it stands. They're not seeing it as a drop. They're not seeing it as a deterioration during winter. They're working to come up with plans to try and smooth that and improve discharge ahead of winter.
I think that's clear in the paperwork. We don't see it as a deterioration, Anthony, but I think there's an artificial divide put in there between the improvement work and the winter plan. It's one of the same issue, and seeking to understand how we can fast track some of that, because we know the impact that will have on our ambitions to not open up additional capacity. Right, I'm going to move us to the request here is to approve the board assurance statement. We've had a good debate. Does anybody think we're not in a position to satisfactorily approve that board statement? Okay, I'm going to, Cathy?
Just say, I suggest, Anthony, for our next monthly meeting, I know you're already working with colleagues to prepare for our next monthly meeting with NHS England, that I'm assuming we're signing this off, we can share this as an update with NHS England. I know there are full processes to go through in terms of winter planning, but we'll do it also in addition to raise awareness with the region.
Okay, so let's record that we've approved the board assurance statement, and we've endorsed the continuing approach to further developing and testing the plans and assuring winter resilience. Thank you, Anthony. It's good stuff. I'm going to suggest we have a few minutes break, 10 minutes break, and then back in. We're nearly at the end, and I've got to go to the loo, so I'm going to have a break.
Thank you. We just need Andrea, Mandy and I need some time together
I'm
on
Lesh anyway.
Monday to do
Hi, so in your packs on page 182, you will have the papers for the work and health strategy. As we started off the meeting, we heard about the real vital importance that good work can have on especially some of our vulnerable communities. And the board are receiving the strategy today, which was a nationally mandated ask from us, from all ICBs, and really contributes towards the fourth strategic objective around our contribution to both social and economic development in our local area. The strategy shows how the NHS and our partners can support people with health conditions who face health and social care barriers to good employment. For example, just some headlines in that you can see over 11,500 people in December were off work with temporary sickness, but nearly 100,000 were off with long-term sickness. Our fit notes were about 7% compared to nationally 5%, so it is a challenge to our economic sector across Cheshire and Merseyside. The strategy focused on 4 key areas, and one was the analysis of population needs, service mapping with our local partners across our 9 areas to develop a work and health partnership and an integrated action plan. At the same time of this work, we really benefited from the healthcare partnership approach. So one of our headline ambitions within that was around work and health, and we've been working closely with where we are today with the Combined Authority in the Liverpool City region and Enterprise Cheshire and Warrington and our local authority growth directors in this space really, which has helped us really create the plans together in a collaborative way, which is something which Department of Work and Pensions recently were really impressed by our approach. The local analysis has been taken to the healthcare partnership previously, and that's also informed all the local plans and the 2 Get Britain working plans, so Get Liverpool City region working and Get Cheshire and Warrington working too. Feedback from colleagues within that and partners has been really, really welcomed. You will see that proposed in the paper is governance around how we actually attend and align these strategies in place for Liverpool City region and Cheshire and Warrington, and that's one of the asks of the board, that we're happy with that governance rather than causing any duplication and looking at this separately. The ICB will continue to be updated, it is proposed, through the Executive Committee via Population Health, but also as the healthcare partnership evolves over time too, we'll be updating them on that work. There are a range of opportunities that I identified within the strategy about how we can make a contribution to reducing those health barriers and issues. So one being crucially the neighbourhood health area, where we can look at co-location, navigators, working with employment support, our voluntary and community sector locally as well. Within that space, we are clearly one of the big employers within the sub-region, but also we play a massive role in making sure people are well and can sustain good quality work. There is also opportunities around data linkages as well, and research and opportunities within that space, and partnership agreements wanting to be aligned with the ICB about how we can proactively support some of our residents who are more at risk of falling out of work or trying to get back into work with their health needs. Big things like musculoskeletal conditions, poor mental health are drivers of reasons why people aren't able to maintain work in many different ways. It looks at a number of cohorts within the strategy and thinking about some of our health inequalities groups, and those groups in particular are children and young people with mental health, carers who are economically inactive, young people in the care system, those who are experiencing criminal justice, refugees, over 50s with skill gaps, adults with social isolation, and importantly women also facing barriers to employment. You've seen the attached reports and which our partners were asked to share and hopefully endorse as well. So the board is asked us to acknowledge the joint work and approach that we've taken. Also endorse the governance that we're proposing to continue, and recognise the vital importance that Get Britain working happens across our two economic footprints with both the Combined Authority and Liberal City region and the Emerging Authority in Cheshire and Warrington.
Thank you, Ian. Comments or questions? Mike?
It's great to see this. Really pleased to see it. There's almost too much that we can do here, and I think capacity is a challenge for us, I suspect. So I just wonder whether we've got to do some prioritisation to think about, you know, out of the 100 or so actions or whatever it is, do we focus down on a smaller number of really priority actions that we can put some effort into it. And the second part is how we're mobilising our provider organisations to get aligned behind this as well, you know, because they've got the capacity out there, they've got the workforce out there, they've got the opportunities out there, and particularly with the mental health trusts as well, which I'm sure it's a priority for them. How do we make sure they're fully on board through our commissioning activities?
Ian, do you want to...
Yep. Thank you very much. Absolutely, with regards to the priorities, one of the specific aspects in the papers to acknowledge we are in changing times, and to recognise whatever the future governance is, the ICB commits to contributing strategic leadership in this space with our partners around that. I think we need to be led by some of our local governments and economic skill teams about the priorities that they are seeking to develop and where we can add value as a sort of convener and a broker in that space more so. And absolutely, unfortunately, I've got our provider collaboratives in the room at the moment, but it's reinforcing the anchor network that we've established there with our providers, and the commitments to that they've made is actually something we can revisit as well on that front.
Important point. I've got Ruth and Andrew, then Del.
Just briefly, brilliant. You know, this is so important that we get behind this. What was nagging me a little bit is how can we be a good partner? What is the ask of the NHS specifically? Great joint plans, we can have lots of conversations, but unless we turn it into real capacity on the ground, helping people day to day, then it's not going to happen. So it's great that the ICB as a commissioner can provide strategic leadership, and it's great that, Ian, that you're doing this already. The next step of this and going into our plan for next year is to say what specifically we're going to commission that's going to be the first step on this plan. It's a bit like Mike's point, but we've got to turn it into what's the ask of providers that we commission, what are we asking them to do specifically. May not be all new money, but we have to have a conversation to make this real. We can't have a plan that it hasn't got that implementation pathway underneath it. So all power to your elbow, Ian. Absolutely support the work. What I want to see is how is it going to actually turn into real process on the ground.
Thank you, Ruth. Important points. But Andrew and then Del.
Yeah, really welcome this. I think it's probably the most important conversation we've had today, actually, in many ways, because ultimately it's fundamental to the transition from treatment to prevention, because that sort of whole person approach and there's plenty of evidence that engagement with the world of work is itself a sort of therapeutic measure, isn't it? So absolutely fundamental. I suppose I had a similar point to Mike, that because actually it's such a big area and it interacts with so many other things we're doing, just being very clear about the contribution the NHS can make. But it is really important that part of that conversation. So often in the past, when we've had big initiatives to make a difference on employment rates or participation in work, particularly at that sort of end of the age bracket where people are sort of leaving work, often assisted by the health system. The health system is sort of enabling them to exit the world of work rather than actually to proactively encourage them into it. So I'd see this as almost a sort of cultural challenge as well as a practical one or a commissioning challenge, you know, how do health professionals seek to support people to remain engaged with the world of work rather than the sick note culture, which can often sort of help them to exit it.
Yes, thank you, Raj. Very, very similar points. I think Ruth's question, you know, what is the ask of health and the ICB and NHS providers is critical. It's a good paper, but it doesn't define the ask. And I suppose my organisation hosts one of these for Cheshire and Warrington, so it would be good to understand the join up and what the contribution might be, not financially, but just in terms of what's going on out there already. How do we really get a sort of collaborative effort and behind this? I suppose the governance, absolutely agree with the governance. That will change for Cheshire and Warrington moving forward. We will be moving into a shadow combined authority probably around February of next year. We'll be recruiting to that combined authority from October of this year, and we'll be recruiting and electing a mayor in May 2027, and we'll also be receiving national funds for skills will drift into the combined authority as opposed to local authorities now. But I see that as an opportunity. So how do we really craft something that's going to be meaningful, link that absolute, you know, work, health indicators, and that sort of rounded mental health and well-being as well. How do we link that far better than we have done previously? So really welcome the paper, thank you, Ian, but I think there's more to do on defining the absolute ask.
Thanks, Del.
I think Rowan and then I'll go.
Thank you. And just to speak to some of the specifics, so I've briefed Andrew already today. I was part of the OPSI meeting the other day, so the Office of Public Service Innovation, which is a fantastic coming together of combined authority here with us. Some of it is you start where you're going to make the biggest impact to the health intelligence, and that's something that we are extremely good at, as colleagues know, through Cypher and some of those platforms. But what hasn't been done before is to link together some of the Department of Work and Pensions data or escalating benefits with health data. And to do that, you need a really good reason to do it. We are on the absolute verge of unlocking those data sets coming together, which has never been done before. So we started to coalesce around things that would make a positive difference on both sides of this collaboration. So one of the ones I put forward is, who have I got sitting on the waiting list now, for example, waiting for musculoskeletal surgery, who is a carer? A carer for someone who is seeing escalating needs because their partner can't help them move around anymore. Because if that dependent ends up in a care home because we've not got on and done timely hip replacement surgery, it's a double hit for me because I need that care home bed to get someone safely out of hospital this winter. So if we can start to find households with escalating needs for benefits and support, which is costing Andrew's side of the fence, and yet we could make a relatively simple health intervention by saying, well, maybe they need to be reprioritised on the list, then those are the sorts of real sweet spot where the NHS doesn't need to put anything extra in, it just needs to work a bit differently, but will make all the difference in the world. So we've started framing a set of use cases that allows us to access the data and then say, so what? And what can we do differently? And actually that's injected some real energy into OPSI because here's a knotty problem that everybody wins by us working together to sort it out. Thank you, Chair.
Rowan, can I just push us more towards, I'm going to call it the worklessness agenda? Your use case is brilliant. We absolutely must do that. If I'm understanding the strategy, we know that there's 100,000 people in the Liverpool City region who we think probably could get into useful work, paid work, if they receive the appropriate support or wraparound. So we're using data to identify, and it's mainly mental health that's causing the main issues, people who are in that mental health pathways and supporting them in appropriate ways into the workplace.
Yeah.
Could that be one of your users?
So the other one, in fact, is those who are not on a pathway, but are seeing escalating fit notes being issued coded against mental health. So what are we actually doing? So who is out there who isn't on a useful pathway or receiving the right set of support? So we can do an initial sort of trawl, a learning exercise across those data sets to see where are the actionable points for our citizens out there where worklessness and health are interacting. So that is giving us the mandate to do it because we're building all these use cases.
And Cathy, included in your comments, could we give us some idea of how we get a process that enables us to turn these fine aspirations into prioritised with our partners' actions? And what does that mean to us in commissioning?
So it complements what Ruth was talking through. This should be part of all our commissioning intentions. If you take the 4 purposes of an integrated care system, this very much supports the 4th purpose, and therefore all 4 purposes need to be part of our commissioning intentions and whatever we're commissioning. It then aligns with our 9 places, and your point about how you prioritise all these different groups of people, the population by each place and by each neighbourhood. If you think through that we're going to have around 50 neighbourhoods, you can then work to prioritise. So you can have worklessness as a theme throughout, but when you get down to the city of Liverpool and then you break it down into the neighbourhoods that you'd have in that area, you would then start prioritising, which would then follow the commissioning intentions and the health and care partnership aims. This is particularly where health and wellbeing boards are really key in coming in through their plans to align with ours as a commissioner, and also how we align with each strategic authority, the one established for Liverpool City Region, and as Del has shared, the one for Cheshire and Warrington currently being set up as well. The system I've come from in working up until May this year, we had worked on having joint roles and joint aims and joint governance, and I think this is a really key opportunity for us to, this is a good example of why we should have combined governance between the strategic authority and the ICB as well, because there will be opportunities in common, including funding, because this very much aligns with the national government agenda, particularly around growth. So that's, and therefore the data sets that Rowan has talked about aligns with that. Something I wanted to sort of go back to, if you remember the patient story or the person's experience, actually, the local residents' experience that we heard about earlier today. Colleagues in mental health in the NHS have been doing this for years and supporting people with learning disabilities into work. So we've already got really good examples of what's been going on in mental health for many years in the NHS. And there are examples, as Rowan's just talked about, how you look at waiting lists, whether it might be a carer or the person themselves out of work, and also how we work with primary care on this as well. So I think neighbourhood healthcare gives us that opportunity to prioritise, but this is really, really welcome. This is 4th purpose work. I'm very passionate about it. I've done research myself on it nationally, and I think this is a really great step in the right direction in working with strategic authorities as well.
Thanks, Cathy. I'm going to bring Hilary in, but let me just ask you a more detailed question, because I don't know the answer. NHS, we're the largest employer by far.
Yeah, it's the other area.
Is it 80,000 people? And the percentage of people who have learning disability who are employed in the NHS is microscopic. And yet we know that people with learning needs can flourish in lots of roles in the NHS. As a commissioner, can we say to Wirral hospitals, right, well, you need to support the initiatives that Del's team is taking forward, and we expect, I don't know, 20 placements and that to lead to 10 jobs per year? Is that something that's doable in commissioning world?
From my experience in the previous system I've worked in, it's possible, but I think it's got to be tailored to that local population and the ability and the gift of those services. And you think about people with learning disabilities, but you also think about people who are looked after children and are coming out of the care system as well. I think that is an extension of protected characteristics. In the previous system I worked in, we established that is a protected characteristic, and therefore as local employers in the public sector, we should be supporting that community of people. So I think this is very much possible. And your key point there is we employ thousands of people between the NHS and local government. How are we looking after our own workforce to make sure that they're healthy and their well-being as well as their physical and mental health are looked after? You can then extend that out in how we work with the private sector, but we probably need to get our own workforce supported fully before we move back into that.
Not quite, Cathy. That's not what I'm saying. I'm saying, how do we break down some of the massive barriers to employment, given that we're a healthcare provider in the NHS, and yet some of the people that we support can't access the NHS in terms of employment terms. We did a few board meetings ago, we made care leave as a protected characteristic, so you're absolutely right to pick that up. We can't forget what we just saw at the beginning of the meeting in terms of the learning disability.
I think,
I'm losing it.
No, it's absolutely, I think it's how we enable public sector employers to bring in a breadth of people who are back into the workplace or into the workplace for the first time in a supportive and inclusive way.
But I guess what I really want is quite a hard stick. I want it to be incorporated into contracts, because that's the only way we'll break through.
Yeah.
Goodwill has never really done it, because we've been around here before.
Okay. We
So
can take that.
I don't know whether
I
you
get
can
that.
or not.
That's my point about commissioning intentions. Thank
Hillary.
you.
Stole my thunder, Cathy. It was about care leavers. And there is something we can do now to really understand the barriers. Locally, we know what they are nationally, because research tells us that. But also making sure that we're capturing them in our data set and prioritising them in our waiting lists, and particularly mental health waiting lists. But that's something we can do now. We can have conversations with them, with our local authority colleagues to really test out what the barriers are and be ready to do the appropriate commissioning that you've alluded to, Raj.
Thanks. Chris.
Just to come back on that, Hillary, we held our inaugural corporate parenting board, which I chaired this month, and that was a focus on the agenda, so that's something that the corporate parenting board for Cheshire and Merseyside will be focusing on.
Good stuff.
It's great, and our care leavers on there, well, young people in care, and they're fantastic, so maybe we need to ask the questions and get some discussions going. Thanks.
Okay. Del?
Yeah, sorry, just on the corporate parenting issue. So every local authority has a statutory corporate parenting board with care leavers on there and with children in care on there as well. So just making sure that we can join some of that up in terms of some of that strategic conversation.
We've got full representation from local authority, and it's co-chaired with one of the directors of adult services, and Zoe Vera.
Okay, it's just because we do so much work on being work ready, mentorship, CV writing, going and working in local businesses, and as a massive public sector there is a huge opportunity that we're still not tapping into perhaps as successfully as we could do.
And just to go back at different ages and stages of children's lives, it's making sure that those looked after children really get the health assessments when they need them, because nationally it's still a shocking picture in terms of how our responsiveness. So it's making sure we act right down the line when they're young, so they're fit and ready for employment.
We heard very loud and clear from the DCSs about the lack of health assessment and support that these generally young people, but it's people in care have. So really important. It's going to take us to what the board's been asked to do to make sure we're really clear on where we're going to go. Acknowledge the joint working and development of the work strategy. That's what we're doing. Endorse the published Cheshire and Merseyside work health strategy and approach adopted by the two Get Britain working plans. Endorse the proposed governance and oversight of the work. We need more work on that, I think, Cathy, to understand how is it that we do connect.
And we need to do that through the strategic authorities, as you know, with the standing down of a health and care partnership, which is probably where we'd more likely usually bring this. We just need to work that through, and it must connect with health and wellbeing boards as well.
Thank you. And acknowledge the progress made. I'm sure we'll acknowledge that. Ian and colleagues, really, I agree with Andrew. It is the most important paper that we've considered today. Thank you. Proposed draft NHS Cheshire and Merseyside Board Assurance. It's the last major agenda item, so let's make it happy.
And the most important you're going to read today.
It is.
So I'm pleased to present the ICB's draft 2025 to 28, Bath Board Assurance Framework and the strategic risks. 2.1 and 2.2 in the exec summary set out our statutory duties, and it's really important. I was going to read them, but I won't. But I think you can read them yourselves in terms of absolute sort of public accountability as the ICB. So I think it's just important where this fits and sits within our overarching governance. So earlier this year in May, we agreed to review the 24-25 BAFs, the principal risks, in light of the sort of changing environment in terms of the organisation, the finance, and sort of changing organisational changes and blueprints, etc. And since then, a considerable amount of work's taken place, acknowledging the wider context in terms of 10-year plan, ICB regional governance, blueprints, future changes for the ICB leadership, the current financial challenges, performance challenges, the existing 4 strategic objectives, talk about the HCP, basically everything that fits and sits within the responsibilities of the ICB. So, Appendix 1 details our draft board assurance framework and its strategic risks. We have shared this previously with board members and at our board development session last week, and I think we got agreement in principle. So what I'm asking today is to endorse and support those risks, and by November we will come back with all sort of worked up in terms of the controls, the mitigations and the ambitions for the organisation. But that is 25 to 28, because rather than keep coming back every year and considering we're signing these off so late in the financial year, they won't change. Some of the risks and mitigations and controls might, but controls and mitigations might not the risks. But I think what I'm asking is that we sort of go for a slightly longer period. And then also in November, we will bring back the board's risk appetite, because we'll do some work in October's board development session on that. And that's really important to sit alongside that. And I think some of the conversations today, particularly in private board, have been around risk appetite. And we've talked about it for a number of months now. And what's our risk appetite, for different parts of our agenda. So that's what I'm proposing. So it's to sort of get the go-ahead to do the work behind this in terms of controls and mitigations. But also in November, we'll bring back, we'll bring the risk appetite statement, which is really important, I think, for the organisation. Thank you.
Thank you, Claire. So board members were being asked to look at that, look at Appendix 1 and think about that being there for 3 years. Are there any significant changes or absences? Go on, Ruth.
I wouldn't call it significant, but I think to make it durable for 3 years, I thought failure to recover access and performance standards would be better described as failure to meet access and performance standards, because recovery has a whole set of connotations in the NHS, whereas we're going to have to meet them. Is that okay? That's just a minor point.
That's good. Any other? Cathy?
Just to put on record, with our last board development session, which was about a week ago, we did have a session with MIAA, who've been supporting us with our governance, where we did a piece of work to make sure that we've got a broad understanding across board members on risk appetite. So there is some initial work, and that initial session will help board members, if they are in a meeting from tomorrow onwards, to be able to talk about that risk appetite approach. But in getting ready for the next board meeting, we can have more depth of work to take place. But what I'd say is this shouldn't, Claire's right, we need to formalise this, but I hope the board development session of last week with MIA will help colleagues take that approach going forward, because we do need to adapt our risk appetite depending on what decisions we're making, because of either the exceptional situation we're in terms of finance and performance improvement at the moment, or being ambitious for the future. Thank you.
Thanks, Cathy. So the two approvals and the one noting, people comfortable with? Yeah, thank you. Okay, minutes of the previous meeting. Any comments, corrections? Seek your approval. Yep, thank you. We can see that the board action log is up to date. It's good, thank you. Any comments on the board action log? No, thanks. And closing remarks and review of the meeting. Brought it in on time. So
Nice. Thank you.
thank you. It's been a long day, and thank you very much for your time and attention. Thank you. It's important stuff. Right, you can go.